Good morning. I'm Samir Mehta, the course director for Lumen Global, and this is the beginning of day 2 in Jaipur. We've completed day 1 of the Lumen Global 19th yearly symposium, and this morning we are doing a most unique, a special, for the first time, a Lumen Global Asian faculty YouTube interview. I would like to introduce the wonderful faculty which we have here, represented from 11 countries. Starting from my extreme right is Dr. Rupa Salwan from New Delhi, India. Rupa, good morning.
Morning.
It's been a pleasure having you here at Lumen Global for almost a decade now.
Thank you so much. It's indeed a joy to be here.
Absolutely. Next to Rupa is for the first time a most remarkable gentleman from Nepal, Dr. Arun Maski. Arun, welcome to Lumen Global.
Thank you.
We move on next to Cambodia and Dr. San Samreni. San, good morning.
Good morning.
Next is Dr. Eric Sison from the Philippines. Eric, good morning to you.
Good morning, Dr. Mehta. It's good to be back.
Dr. Juzar from Indonesia.
Good morning, Dr. Mehta.
My very good friend, Dr. Muhammad Rosli from Kuala Lumpur, Malaysia.
Good morning, everyone.
And just to let you know, he's coming from the place where we just completed Lumen Global 2017. To my left now is my most special friend from Thailand, Dr. Damras Tresukasol. Damras, good morning.
Good morning.
And for our viewers, Lumen Global did 2 annual symposiums in Bangkok, Thailand. None of those was possible without the profound help for Dr. Damras. Damras, thank you so much. Next to Dr. Damras is Dr. Win from Myanmar. Dr. Win, good morning.
Good morning, Dr.
Year
Mehta.
4 or 5 for you?
5 for me.
Wonderful, wonderful, and we are keen to hear of the progress. There is a Lumen Global interactive session at noon today where we'll be getting progress from 5 of the countries represented here. Next to Dr. Win is from Bangladesh, from Dhaka, Dr. Tawfiq Haq. Tawfiq, good morning,
everyone. Good morning.
I have enjoyed coming and working with you at the National Heart Foundation, and I can attest it's one of the best places in the world for PCI. Next to Dr. Haq is Dr. Neeraj Bhalla from New Delhi, India, my hometown. Neeraj, an
Good morning.
absolute pleasure, and thank you for your most fantastic presentation from yesterday.
Thank you, Samir. Good morning, everyone.
And finally, on my extreme left is for the first time a remarkable physician from the lovely island nation of Mauritius, Dr. Sanjeev Jugesar. Sanjeev, good morning to you.
Good morning, Dr. Samir. Good morning, everybody.
So with this wonderful faculty, we are going to unravel exactly the challenges that confront us in STEMI interventions in Asia. I'm going to start with Rupa on the extreme right. Rupa, we hear the amazing possibilities of the newly announced Modi health plan, which could bring in 50 million people into the healthcare, provide them with funds to get treatment. Would some of this be helping STEMI interventions in India?
Yeah, we are all very excited with the announcement of our Prime Minister, and we sincerely hope it will translate to better care for patients with STEMI. As it is, it's not a disease, it's a disease of all social groups, and as much the middle class and the low class is affected, access to treatment and timely treatment and costs have always been an issue. We are very hopeful by 2nd October when it's being launched, when the understanding is clear of the center and the state partnership. Yes, I do look at it converting to funds to treat patients, and for a disease that gets them back on their feet, and it's a one-time treatment. So we are all excited about this announcement, and we hope that care in our area improves with this scheme.
Excellent. I believe that is a very important political development because without governmental support, without funding, without insurance capabilities, STEMI interventions cannot go that far. Neeraj, same question to you. How do you see this political benefit? Does it help the care of acute myocardial infarction in India?
Yes, the measure that has been announced by the finance minister, which is proposed to cover maybe half the population of the country. It's 500 million people that is being proposed to be covered by this scheme. And clearly, we know since our country does not have a social security network, many people who suffer from cardiovascular disease are unable to get treatment simply because they cannot bear the costs. That seems to be the issue rather than accessibility. And once the government comes up with a scheme like this, which is 5 lakh rupees per family per year, which is a substantial amount, they will be able to negotiate with many of the private medical healthcare providers. We know in India about 70% of the population takes healthcare from private players, and with such a rate negotiation, the government, I think, will be able to extend the benefit of care to a vast majority of its citizens who are indigent or near indigent.
Excellent. Both Dr. Bhala and Dr. Salwan have echoed the same sentiments, and I certainly hope and wish that this becomes a boon for acute MI management. I'm going to move straight on to the new two people who have joined us and get a little status update. Arun Maski, what is happening? Nepal is not an area where most of us are familiar with the PCI status there. Tell us how many institutions perform PCI, how many PCIs are performed in the country, how many operators are there, and what is the approximate number of primary PCI?
Well, we are quite far behind. We started cath lab in 2002, and in 2014 the total number of PCIs done were 1800 in whole country. Now we have 15 cath labs. 2017 it's expected just 3500 PCI per year. So most of the cath labs are concentrated in Kathmandu. We have 7 cath labs. New cath labs are coming. Interestingly, there are few hospitals with cath labs, but there are no operators. This is very interesting. And our primary PCI rates in Nepal is 33% of total angioplasty is done. And surprisingly, only less than 40% of the patients, they reach hospital within 12 hours. So the constraint is we have lack of manpower, we have lack of awareness, we have lack of trained personnel, we have lack of health facilities, and the major constraint is cost. Interestingly, the government of Nepal is quite moving forward. I can give you a few examples, like dialysis in Nepal is free. If a patient goes for renal transplant, he gets from government 450,000 rupees. And the valve surgery is totally free. Less than 15 years and above 75 years, the cardiac treatment is free once the patient is admitted in hospital. Balloon mitral valvulotomy is totally free, and the government gives 1 lakh per person if the patient is admitted with cardiac problem. So if you look at the cost of the procedure, it's around, for one stent with angioplasty is around, in government hospital is 1,50,000. So if the government is giving 1 lakh and there's no insurance policy. So these are the constraints where we're trying hard. Maybe if you talk with government, maybe with the Lumen Global, if I have infrastructure, the working of Tamil Nadu and other hospitals, if they are working, I can coordinate with government and make primary angioplasty available to all. Maybe we can talk with the Ministry of Health, and we can make that service accessible, because government is already giving 100,000 rupees. What we need to add is 50,000 extra. That I think is possible in Nepal.
Look, that's a very comprehensive review. Not only have you provided us the status, but precisely what the challenges are, and more importantly, you seem to have uncovered the solutions too. Of course, we are keen to help advance the status of AMI management in Nepal, and of course I'll discuss with the Lumen Foundation and see how to activate some of the resources of the Lumen Foundation. Sanjeev, same questions. Educate us a little bit more about Mauritius, and I am going to request all the panelists to speak a little louder.
Yes, so Mauritius is a small island in the Indian Ocean. Many of you I know have been there. It's a tourist resort. We are around 1.3 million people, and we get around 1.3 million tourists every year. It's not a big amount, but we have a high level of diabetes. 25% of the adult population is diabetic, and another 25 is pre-diabetic. So this is a huge epidemic at our place, and 30% of the adult population is hypertensive. So couple diabetes and hypertension together with hypercholesterolemia give us a high level of ischemic heart disease patients. And we do about 5,000 coronary angiography per year in the private and the public sector. And out of these, 2,000 will go for around 2,000 PTCA and 600 cases of primary PCI. The funding, we have a health sector which benefit from a welfare state like it is in UK. It's a copy of whatever is there in UK. So the government pays primary PCI, coronary angiography free of charge for people attending the public hospital. Of course, you have a system of waiting list, everything. It's not that. And in the private sector, mostly funded by insurance companies and people paying out of pocket. So their primary PCI is very fast. We have all the consumables that is used in Europe, everything that is there in Europe, America, in India, everywhere, the best ones. And it's affordable for, let's say, 25% of Mauritians, especially out of pocket. Insurance is not a problem. Insurance company, they pay. And there is a limit, of course. We can't use whatever consumable we want. There's a control on it. And somebody in Mauritius can get an acute MI and go to the hospital. In the government hospital, we have 3 centers performing coronary angioplasty, primary PCI. 2 centers 24/7, 1 center 9 to 4. It's because of capacity building. We are still working on it to improve this. 2 other hospitals do not have facilities for coronary angiography and angioplasty, but I think in the future it's going to come. But the mortality now for coronary artery disease is decreasing. The prevalence has increased, but the mortality is decreasing because of accessible treatment, and people are becoming more and more aware of coronary artery disease. This is a bit about Mauritius.
Look, I am reminded as I hear the status of both PCI and primary PCI from Nepal and Mauritius, as explained by Dr. Maskey and Dr. Jugesar. This was almost exactly the situation in Myanmar 4 years ago. I remember chairing a Lumen Global Interactive session where Dr. Wen talked to us. It was also very similar to when Dr. Sokchur had explained about Cambodia. We welcome you to Lumen Global. We hope that the meeting will serve as a catalyst for improving AMI care in your country, and of course we'll try to forge a stronger collaboration. To Dr. Wen now, what is happening further in Myanmar? In many ways more political stability, but that unravels very quickly, as we have learned this year. Making progress with primary PCI?
Yeah, initially primary PCI was started only in the Mandalay General Hospital in 2013, but now the other 5 government hospitals, the 3 civilian and 2 military hospitals. And the other 4 private hospitals, they start doing primary PCI. So in total, about 8 PCI centers doing the primary PCI. But unfortunately, I cannot get the data from these hospitals. Based on the data from my hospital, the STEMI process wise, we created a network in 2015, and we ran heart attack awareness week program. So the door to balloon time dramatically shortened from 92 minutes to 50 minutes, and in hospital mortality from primary PCI also decreased, initially about 5% to nearly 1% only in last year. And regarding this network referral system and the public awareness, more patients come in hospitals and late referral become less and less. So overall STEMI mortality in hospital mortality, compared to 2013 and 14, and that dropped to 3%. So initially about 14% to now dropped to 11%. And the government is subsidizing some balloon and stents for the primary PCI. So once patient called AMI, if they go to government hospital, they were charged about 200 US only. They don't need to pay for balloon and stents. But if they go to the private hospital, still a bit expensive. It costs about 10 to 12, 10,000 or 1,000 to 1,200 US dollar per procedure.
This is amazing progress for PCI and primary PCI to advance to so many new centers. I also congratulate you. I know that a lot of this has happened from your efforts. Take us further through. Let's be a little more intelligent here. Let's try to see what are the further areas of improvement. We've noticed in many countries that although the door to balloon time improves, it is the symptoms to first medical contact which remains a challenge. It is the time to presentation which is much more harder to do. And of course that is also so because patient awareness is much more difficult. The lack of infrastructure, the lack of ambulances also contributes to it. What about those areas? Have they started improving too?
Yes, compared to the before and after the STEMI network, the symptom to door time stay more or less the same. The mean time is about 6 to 7 hours.
Yes.
That doesn't change
Right,
a lot.
right.
Yeah.
Exactly. Look, this is precisely, see, 5 years, 6 years ago when we started talking about countries which were starting PCI, and I firmly, clearly remember Myanmar and Cambodia to be amongst those. The door to balloon time, door to needle time, those were good initial parameters to follow, and now that we are exploring further, it looks like there are several other areas, and again I think emphasis should also go towards patient education, which is not necessarily going to be just the job of the cardiologist or the interventional cardiologist. You need the press and the media to play a very active role, and I hope that you're finding ways to encourage them. I'm going to move now to the Philippines. Eric, progress there. A very large population, huge population density, a lot of challenges because of geography. Things getting better?
Yes, I think in the Philippines there has been some improvement in terms of STEMI care. One of the primary issue that we had was actually cost of the procedure, because the national health insurance system only covers about 10% of the actual cost of a primary PCI procedure. So it's really very hard for middle income or even lower income people who come to the hospital to consent to a primary angioplasty. And we are continually lobbying with the government to increase the subsidy for these procedures. And the initial talks have been promising, but I think it will take some more time for them to really implement these changes. Another challenge that we face is we don't really have a formal STEMI network to speak of on a nationwide level. Most patients will still be consulting on their own, transporting themselves to the hospital if they have chest pain. So we don't have yet formal referral networks from other hospitals to refer patients to the primary PCI centers. But the Philippine Heart Association and the PSCCI is actually doing some coordination with the emergency medical services to implement STEMI pathway for at least in the city and eventually hopefully in the outlying provinces maybe within this coming year. So we still have a long way to go, but we're learning a lot from these meetings, and hopefully we'll be able to apply these things in the Philippines.
Fantastic, Dr. Samrini. What's happening in Cambodia? I know the last time we heard about Cambodia, there were one cath lab was operational in the capital in Phnom Penh, and another was coming up. I am sure since that time much progress has been made.
Yes, after the join Lumen Global in 2015, Cambodia has been some improve. Now we have 4 cath lab in the Phnom Penh. One is civil hospital, another one is cath lab in the military hospital, and 3 in the private sector. And the cath lab that take care of the primary PCI has only civil hospital and the military hospital. For the STEMI care now, for my Cambodia Heart Association work hard on it to create a STEMI learning and STEMI network to avert to the general population to avert about the acute cornea syndrome and early symptoms that they can get the treatment, get the management on time, and that is the main topic of our Cambodia Heart Association. For this year, the STEMI care in our country is improved from the number of STEMI increased from 352 in 2014 to 452 in 2017, and the number of the primary PCI also increased from 49% in 2014 to 74% in 2017. And we also get a surprising firm medical contact that the patient come less than 12 hours has increased to from 48% in 2014 to 68% in 2017. And we still need to work more to create a STEMI network to all the country to get the more patients to come on time.
What is the situation with the thrombolysis in the country?
For nowadays, the thrombolytic therapy, we don't use it yet in Cambodia, and it is the plan that our Cambodian Heart Association want to create it in the near future, but it's still requirement of highly training in physician and nurse, and also the fund to create it.
So you're telling me there is absolutely no use of thrombolytics in the country?
No thrombolytic use in my country now.
That needs to change, no? I mean,
Yes.
I am as a strong advocate I am of primary PCI in a country, and Cambodia is fairly big, and with such limited access to catheterization laboratory, that to me appears in some of the Lumen Foundation work breaks down 4 phases of development for primary PCI, and phase 1 is almost always universally the use of thrombolytics, which initially starts and then is a universal mandate for the entire country. I am very surprised.
Yes, that is our president of Cambodia Heart Association want to change it, but we still need time to arrange it, because now uh, we work hard on the STEMI network. We go to all the province in the country to update management acute coronary syndrome to all the general physician practitioner in the province to know how to manage it. And in the near future, we plan to put to to achieve that we have the thrombolytic pre-hospital. That is the main.
Right. Look,
the main
even if it
policy.
is not pre-hospital, I think
Yes.
it needs to have at least the basic availability of streptokinase for every citizen. But we'll explore that, talk about that further. Dr. Juzar, Indonesia, massive country, so many hundreds, thousands of islands. And from the last report I heard, numerous exceptional STEMI networks and centers of excellence in the capital region, at least. Is that correct?
Yes, that's correct, Dr. Samir. In the capital city itself, I think we started primary PCI since 2007 regularly 24/7, and then on the 2011 we start developing a heart call center, and then in the 2014 we were fortunate to have universal coverage, so it's actually can cover all of the citizens of Indonesia to get a reperfusion. But what we've learned is from our STEMI network that we still, like you've mentioned before, we still the reperfusion rate is not as high as we hope. It's around 60%, and mostly due because of the patient coming late to the hospital who's doing the reperfusion, and half of those patients actually came into a health facility which not performing perfusion. Now we are in our network, we are keep educating and then train them as well, and also collecting data to identify a room of improvement. I think also in one city, I think there is a disparity in a mode of reperfusion, but at least in general, there's not between tertiary and secondary, the rate reperfusion is not much different. It's between 58 and 62%. It's just the mode is quite different. In the tertiary, of course, is almost 97% is primary PCI, where they're in the secondary facility is usually 50-50 between primary PCI and fibrinolytic, and that I think mostly due not just to the intervention cardiologist, also to the nurse and the technician that's available in the facility to offer 24/7 services.
Wonderful. Moving on to my left, Tawfiq, I hear of tremendous progress being made, at least in the major cities. What's the overall situation in Bangladesh?
Thank you very much for the question. Actually, situation has improved a lot over the last 5-10 years. Cath labs, many tertiary centers are capable of providing cardiac support, STEMI intervention. But the problem lies, as you said, from onset of symptom to first medical contact. This portion. So people are generally unaware of their disease and how devastating can this disease be. So actually we are now targeting this section to create awareness among the people that cardiovascular disease is quite easily treatable if you present early and go to the right place.
Is PCI, now primary PCI, being offered in every major city?
Actually, the setup is there. The thing is, we lack trained cath lab staff, not doctors. The other parts, nurses, technicians. As you were saying, that doctor has only a small part to play.
Absolutely.
So this is our next concern. We are actually training in two institutes are actually training has started 4-year course for technicians, and we hope very soon this problem will be.
What is who pays for the procedure in Bangladesh?
It's actually in every place it is out of pocket expenditure. In the government, there's only one government institute, and their angioplasty is free, but you have to pay for your stuff.
And what's the situation with the availability of ambulances?
That's actually not very encouraging. Actually, the ambulances what we are using are microbuses with an oxygen cylinder, and the staff, they have absolutely no clue about how to manage a patient while they're transferring it. So this is another section we are targeting.
Availability of thrombolytics nationwide?
Yes, availability of thrombolytics is there. Nationwide it is there. At least in the district towns, there are facilities where when a patient can get thrombolized if he comes in time.
Some experience with the pharmaco-invasive management?
Actually, as you mentioned yesterday, pharmaco-invasive is going to be the main treatment modality for our country for next few years, and it's when a patient comes to a medical contact with MI, they immediately get thrombolytic, and the doctor immediately advise them to go and get a PCI done. So this network is working good for us.
Wonderful. Look, I deliberately went through some of the, the plan was first to know a little bit more about Nepal and Mauritius. And then I deliberately went to the countries which had started STEMI work before focusing on Myanmar, Cambodia. And now to my extreme right and left are places where I know the system is more sophisticated. Rosli, things have improved a lot in Malaysia?
Yes, it has, Samir, and I think that was the push that Lumen Global had when you had a meeting with us in 2016, so we are very grateful to you. So we actually set a national pilot program around the KL Kuala Lumpur area, which has a population of 8 million, and that is with 5 hubs and a number of spokes hospitals. And we set the processes in place and the key performance index so that this we can be audited regularly. And it is good to note that firstly, the number of cases have actually increased. We have a national registry that we report every couple of years, and the last one was in 2011-2013, and only 10% of patients received primary PCI for those patients with STEMI. But we have actually done 3 times more than what was reported before, so that actually has been an improvement. Secondly, what I'm so grateful is that we have been working very well with emergency medicine physicians, and that's very key. And
they were a very large component of the delegates at
yes,
I think right.
And what we did was we looked at our processes and improved processes. So the ECG time for first medical contact in the spokes hospital has actually improved from about 25 minutes to now 9 minutes. And that's the KPI of having it less than 10 minutes. The transfer time has now been to an acceptable level, which is 20 minutes, and we specified that it has to be less than 30 minutes. So overall, that has improved from their point of view. In fact, from our door to balloon time, when it comes to the hub hospital, that has also improved from about 150 minutes to now a median of 95 minutes. Some of the hospitals too at least did much better to achieve it about 40 to 50 minutes. So looking at all this, we've seen a great improvement in terms of the achievement. The only problem that we have is that the time that a person comes with chest pain to the first medical contact has remained the same, 2.5 hours. and this is something that we need to look at.
Look, it took the United States almost 2 decades of consistent, strong press, media, patient awareness campaign, every society of cardiology, every meeting focusing on that. It's not easy to do, but I think with persistence it will happen. And of course, there is a major role of press and media. Damras, almost the same encouraging signs like from Malaysia happening in Thailand now?
Yes, now the STEMI has been treated nationwide completely. There's no problem in accessibility. We have much more PCI center in all regions in Thailand. We have 13 zones in the whole country. And now there's no financial barrier because all STEMI can be treated free either in public hospital or in private. This command by the law recently applied to whole nation. So I think in the future we are strengthened in the education to patients, and second strengthen to the STEMI network. We empower ER physician to do it correctly, read EKG, and activate STEMI through their regional AMI center. So that is the new progress in Thailand.
Look, to me, my most profound observations as I listen to the group is how tremendous the variability is. You have a nationwide mandate by the government to provide AMI care in Thailand, and next door in Cambodia there is no availability of even the most basic thrombolytics. You have the world's most incredible and efficient STEMI system in Singapore, and there is a struggle all around in Indonesia. Of course, the challenges are totally different. But the theme to me is very clear. It is being recognized both by the government, by the private hospital, and in various forms of public-private partnership. The care is getting better. And I am delighted that the focus which we started almost a decade ago to help the developing countries in the Asian region is finally bearing fruit. In some cases, the stories have been very heartening. The progress made in Myanmar, in Cambodia. Hopefully, we'll be able to show improvements also with Nepal and Mauritius. Mauritius, I think, should be straightforward. It's such a lovely location with its fantastic French and continental legacy. I think it's only a matter of resources and people understanding navigating an island should not be difficult. I say it because 12 years ago or 10 years ago, I created PRINCE, which is Puerto Rico, in fact, nationwide collaborative experience. We networked 9 hospitals, 35 interventional cardiologists, 82 general hospitals, 762 ambulances. Mauritius looks to be a straightforward carbon copy of how we need to do. I'm going to go back to our Indian colleagues here also because as I proclaimed yesterday, the real mission of Lumen Global 2018 is to make a difference in India. Neeraj, there cannot be a larger collection of intellect. There cannot be more profound gathering of extremely bright and interventional skilled cardiologists. Some of the best operators are around us. Some of the brightest people are committed to this. Yet, India seems to be struggling. We can't get the resources to have reliable ambulance services. There is a complete and a total maldistribution of cath labs. The patients are presenting extremely late, and the country is virtually except for some pockets in Tamil Nadu, in Kerala, the country is devoid of any STEMI networks. Am I being too critical here?
Not at all, Samir. You have seen the situation and assessed the situation, and this is exactly how it obtains. Unfortunately, I think we all recognize, and all the people who've done great work in Thailand and in Malaysia, that STEMI management is a much larger issue than just doctors and cardiologists. And you must have the leverage to energize other agencies like the government, your colleagues, and then establish a system of care. I think what Lumen, the primary gain that I believe Lumen has done for me is to emphasize how much more important the process is. We are excellent in the procedure, no doubt, and that is our professional training and our intellect and our area of interest. But to improve STEMI management, as can be seen, is much larger than that. And the questions and the answers are beyond us alone. We can energize, but we must make the policy makers realize what is and shine the light in those areas. In India, there is a movement and there is a setup for national for non-communicable disease database being formed, and also to give more policy and more strength to finding solutions for this. But the problem that seems to occur in India is that the policy makers are from the government, and they believe that the government only can provide the solutions, whereas the public, 80% of them or 70% of them rely on private care. So unless there is an understanding and hand-holding and synergy between these two, then unless that happens, it's not going to make a difference.
Yet there has been tremendous progress, particularly in the area of people who are covered by insurance.
That's true. That's true. In terms of accessibility and in terms of affordability of treatment, but as far as forming networks go and as forming a system of care, and I think STEMI is all about forming a system of care. Absolutely. And a planned way, that is still lacking.
Rupa, role for telemedicine in India?
Actually, I would, before that, just add one more thing, that
Absolutely.
it's basically it's a journey of teamwork, mutual respect and trust. And we don't need policies to do that. We've just got to start doing that. These are more human factors. Well, he correctly pointed out that healthcare is largely delivered by the private sector. We have to have the rules of sharing. Even if the government stretches itself, it cannot deliver. See, just putting up structures is not a timely delivery of care. For example, in Delhi, the government of Delhi just has 3 or 4 cath labs under them, when we have about 70 cath labs in the city. So regulatory is going to be more about mutual respect, and we cannot do down each other, and we have to find rules which work for the population. And that's how access happens. But press which has taken the liberty to criticize medicine to a very unfortunate level today has to stop. And there has to be accountability in how we go to the public and the masses, and just creating mass hysteria or mass, confusion is not the way ahead. So we need to be more responsible with the tools we have to reach out to people. Telemedicine, yes, it has a very important role in our country. Because, at the periphery where we have general practitioners or we have other people in PHPs, all they need is a little okay from somebody that yes, it's a STEMI, go ahead and lice. All of us know that thrombolysis works, and there are people who do come from smaller towns, train in bigger centers and go back. But our reach to many more would increase if we can link up and just hold their hands through their problems and help them set up their centers. So telemedicine, it will help, but again it's about, you can't impose it. It is going to be indigenous people using these tools, connecting with us, rather than we going with plans and imposing it on the population.
Samir, if I may ask,
yes, please.
Developing on the telemedicine question, what is the cost of setting up a Rahat spoke and hub system if it is to be
exactly
adopted?
For the viewers, let me first explain to them, give them a little background. So some of you may have heard of our experience with the Latin program, which is Latin America Telemedicine Infarct Network, created in partnership and support from the Medtronic Foundation. The program, I think, has created a global template of how telemedicine could be applied. At the moment, we have 257 centers in 3 countries in Brazil, Colombia and Mexico, with some absolutely unique features. As an example, the 51 centers in Mexico are all being monitored and managed through Bogota, Colombia. There is no central command site in the entire country of Mexico, and we are now going to use the same example where Chile is going to be guided through Brazil, and Peru, Argentina and Uruguay, which are also coming in collaboration soon, will also be monitored through Colombia. So, and the total number of patients, and this is where Rupa and Neeraj, you will understand my frustration. At Lumen Global 2017, I presented data that we had triaged and provided care to 170,000 patients in 92 centers in Latin. That was last year, 170,000 patients in 92 centers. In 2018, in 12 months, that has gone from 92 centers to 257 centers. The number of patients has gone from 170,000 to 520,000 patients. We've just crossed 500,000 patients. The speed with which it has progressed is amazing. I cannot thank the Medtronic Foundation enough for it, which also brings me also, I'll talk to you about as one of the last questions about the role of industry and some of the issues, particularly in India, about some capping of some pricing issues, which I think kind of play into it. Neeraj, coming back into Rahat, everything which I learnt over the last several years with the Latin, we incorporated onto it indigenous developed technology from India. Cloud computing, parts of artificial intelligence, a lot of big data use, GPS navigation, and we created a most magnificent Rahat program, which I can challenge as the most sophisticated telemedicine guided population based program. The cost of that at the moment is about 2.5 lakhs for the spoke and about 8 lakhs for the hub, and it is going to come down. There is already inbuilt profitability in it, which I think needs to be structured backward. I think this provides not only a very efficient but also a cost-effective way of providing care. The way the Rahat program is structured, we can cover have about 5 hubs and 42 spokes. The command center at the Eternal Hospital is already functional. Every component seems to be working extremely efficiently. But yet, once again, I am surprised why it is taking so long, and I have every intention to stand in front of the mic at the podium today in 30 minutes time and make a personal plea to the physicians in Rajasthan to utilize this service. What comes to your mind, Neeraj, when you hear that this is the cost? Does it make sense for your wonderful BL Kapoor Hospital to use this technology?
I will take what Dr. Tan Hui from Singapore said, that for whatever you spend, you have to show the value.
Absolutely.
And that will come from showing quality improvement versus cost. So I think it's not possible for me to say.
Right.
Of course, the overall cost seems to be a fraction really of what we are able to and what it can do for us. But for the hospital administrators and for smaller hospitals to invest in this, I think value needs to be shown.
Neeraj,
in a city like Delhi, I'm sorry.
No,
in a city
proceed.
like Delhi,
right.
Our problem seems to be water everywhere and not a drop. We have more than 75 cath lab centers, most of whom are offering PCI 24/7. So we really don't know how to build a network, because smaller hospitals and patients can access primary PCI within 30 minutes almost anywhere in the city. So we have a different problem.
Is the reason or one of the reasons for not being able to develop a STEMI network, is it because of the hyper competitive atmosphere which occurs from so many cath labs?
Sure, I think so, yes. I think so, yes. Since most of these labs are private. In fact, even in, I will dare to say that a patient who is thrombolized in a smaller hospital, it is in the interest of the hospital and the owners of that hospital to keep that patient inside the hospital for as long as they can. Because unfortunately there is no regulatory, and we are not able to show them value of, if the patient goes away from the center, then they lose the patient. We have to show them the value, and I cannot see a clear path to that.
Right. You are absolutely correct on this. One of the themes which we touched on yesterday was that some of these obstacles and hurdles which are happening to you all over seem unique to you. They are not. In the United States, we have gone through exactly the same issues. What you have mentioned, we experienced it all along, but gradually with press and media taking the message and the patient awareness, that is now impossible to do. Plus, of course, in the United States, one of the things which makes you follow guidelines and continue to improve systems is the legal burden which we face, which is also a particular driver. I'm going to focus on one last issue before we conclude the session, and this is not an easy topic. I'm going to direct this query both to Dr. Neeraj Bhalla and to Dr. Rupa Salwan. It is a topic which I think it would have been very convenient for me not to address it, move away from it. Why do I need to be embroiled in controversy? But it is becoming an important determinant to how care could be provided. When I started providing STEMI care, my first international foray was into Dubai, into Puerto Rico, and then into mainland China, where we helped construct a nationwide STEMI program. None of this was possible without the support I received from Abbott Vascular. It was simply not possible. Following this, the same organization helped us in several countries, and then we started the most incredible telemedicine which has functioned now with the Medtronic Foundation, and which has also helped us take the message on to numerous countries. I have always said it openly that without the support from industry, some of this work is not possible. Now, when you take the price of one of their products or some of their products, and there is a mandate to be paid a fraction of it, is there any room or incentive for these companies to help us develop STEMI initiatives in some of the regions which we are representing today? Rupa?
I think it's a very important issue where the entire pharma or the device industry is contributing back to the growth of the subject. It's in their interest to see that the subject, the profession, the work we do grows, but it is not structured. So while your agenda is very clean and it is about promoting STEMI care, there are a lot of meetings that are being held without clear agendas. And I think where the government should really clamp it is paying for meetings and systems which are not helping the community at large. It's a great way to go back and do something for society, but unfortunately, it wouldn't be, unfair to say that almost 70% is not so structured at seeing the amount of money that's spent on meetings. If it was for welfare of the community, we would have seen much more.
Completely agree, Rupa. But I'm talking more of STEMI programs and networks,
so
and not meetings.
So the funds, I say that the funds that have been spent on meetings, if they were put into a program, the funds are there. We just have to reallocate them better. And then again, the cost of care, see, the cost of care cannot be the cost of X, Y, Z consumables. It is outcome. Why is nobody measuring outcomes in our country? I mean, you take a government setup and you see what the government puts on infrastructure, electricity, water, cleanliness, and drugs, and what are the outcomes? If the government sector is not willing to discuss outcomes, I mean, if a STEMI is not being done, even the city of Delhi, no government institution is willing to publish outcomes. They go to balloon times. We are not on the same platform. We've got to be accountable.
Right. Neeraj, same scenario. That possibly is a sign for us to stop soon.
I think this subsumes itself into the larger question of why this regulatory came about. And it did come about because the public and the government perceived that there were unfair profits being made by hospitals and the companies. So I think we have to bow down to this, and if this is fair for our people, we have to go with this. And if the price to be paid, I think Rupa said it well, there are not many initiatives in our country, unfortunately, in setting up STEMI programs. So really the loss is notional. And you, from a very sincere, from the point of view of Lumen, feel it more sharply than I think most of the other people.
Right.
So
yeah, Rupa, go ahead.
Yeah, so in this context itself, of outcomes and collaboration and doing things right, I think we have to take larger steps which change really the way medicine is practiced. So it's the government, what I was wanting to say was, setting up, giving healthcare to private sector was the government's decision. It wasn't ours as doctors. And it was not a model where, corporates as a social responsibility are putting hospitals which are financially accountable but not for profit. We were not part of the decision to make hospitals profitable. And that government has to introspect into why they gave those permissions.
Right.
May I ask Dr. Damras and Dr. Rossley whether industry played any part in helping setting up their networks, and if you could, shine a light in that area?
Yes, I would say yes, because Medtronic actually came and helped us by giving an unrestricted grant. And in that grant, they allowed us to actually hire a manager to actually look into this and coordinate the program. At the same time, they actually gave us the access to how they actually helped other countries. And that was actually a help. And, they brought experience from Jakarta and how it was conducted, because we were fairly similar. And that got us going. And now we have actually started paying these people on our own. And we've taken over. So, but it was a good help from the beginning.
For Thailand, we don't have the industry involvement in the STEMI setup program, but it is intention of the government itself that they want to improve the STEMI care saving life by setting up the regional AMI center, regional cardiovascular center among the region, among the country. And we are on the process of to improve the STEMI process, not the procedure, as you mentioned. All interventionists know how to play, how to treat the patients, but the STEMI network, that is not depends on the industry, but it depends on our regulation.
We are going to conclude at this stage, just about 20 minutes to start the formal day 2 proceedings, but I do have a few observations in closing this wonderful session. I want to thank each one of you, and I am delighted that the Lumen Foundation made a decision to do this YouTube interview with the Asian faculty. The most profound observation I have is how fortunate we are in the United States and in North America and Europe. The challenges which you have of lack of resources, lack of infrastructure, an absence of STEMI networks, no clear pathways to patient education and awareness, the struggle with the insurance and payment issues, I am indeed blessed. If the hardest thing I end up doing in life is to to show up at 3 in the night and everything else is set for me, it is I think not too big of an issue. I think I also recognize clear progress in all the countries that have been participating with us. I am always touched by the very powerful intellect in India. I have absolutely no doubt whatsoever that when this event is going to move, it's going to change global mortality because of the size of the population. Once again, I thank all of you. Let's go ahead and have an excellent day 2 of Lumen Global, and it's been a pleasure bringing this interview on YouTube. Thank you.
Thank you.
Thank you.